and good afternoon. Welcome everyone to this very interesting webinar, Conduction System Pacing, a fresh look. And we have our esteemed colleagues, Professor Marek Jastrzębski from Krakow and Professor Oscar Cano from Valencia, Spain with us. And we'll have a short introduction and presentation by both of our colleagues here. And then we have some discussion and question and answer sessions from the team. Can we have the first slide, please? All right. Can we advance the slides? Okay. Next slide, please. So over the last few years, conduction system pacing has rapidly evolved. This is based from a recent consensus paper document from European Heart Rhythm Association, where Professor Jastrzębski has been part of the writing group, and both of our colleagues also were part of this. And we have moved from defining as his bundle pacing to different parts of the conduction system, including right bundle branch pacing, left bundle branch pacing, and fascicular pacing, and septal myocardial pacing. Next slide. And procedure endpoint is quite clear for patients with his bundle pacing when we can confirm his bundle capture and bundle branch block correction rather easily. And you can see that it's different criteria, but they're rather very straightforward and can be confirmed quite easily. Next slide. However, left bundle branch capture has become very nuanced and challenging, and many of us have worked hard to try to develop guidelines and criteria to perfectly identify left bundle branch capture, but it's a work in progress. As you can see in patients' scar and conduction disease, it becomes challenging. Next slide, please. And these are all criteria from the European Heart Rhythm Association consensus document, and Professor Jastrzębski will go through some of them, how to apply an individual case scenario. Next slide, please. And the other thing important is that several tools have been developed compared to the initial very limited tools available. Almost all of the manufacturers have specialized tools for delivering conduction system pacing, and all of them have got approval for left bundle branch pacing indication for their pacing leads. Next slide. And we can see the number of publications on conduction system pacing has significantly increased over the years, and both left bundle branch pacing and his bundle pacing has significantly contributed, such that the level of publication is now outpacing any biventricular pacing related literature. Next slide. And just looking at the Medtronic 3830 lead alone, which you can see the use has skyrocketed in the last 5 years. I think it's about more than 600,000 leads implanted, and similar increase in use of other stylet-driven leads will be seen fairly quickly. Next slide. Keep going, please. Next slide. Next. And this is one of the CareLink data which showed the prevalence of conduction system pacing over the last 3 to 4 years. You can see left bundle branch area pacing has significantly taken over, while his bundle pacing has significantly decreased. But I think with the upcoming new changes in lead technology and delivery sheet, next slide, you can see we can predict that both conduction system pacing, either using his bundle and left bundle branch area pacing, will significantly outpace traditional RV pacing, such that it can push RV pacing out of our pacing armamentarium. Next slide. And it's a possibility that we may have leadless conduction system pacing within the next decade. Next. All right, now I would like to, with that introduction, I would like to invite Professor Jastrzębski to give us the presentation on where we stand on his bundle pacing and left bundle branch area pacing.
Everyone can hear me?
You may be on mute.
I'm mute? No. Can you hear me? Hello? Yeah, okay. My task is to talk about his bundle and left bundle branch area pacing for CRT. So how to resynchronize using conduction system pacing. And I will focus more or less on the things mentioned in the paper that we prepared for the CSP issue of Radcliffe Arrhythmia and Electrophysiology Review. Please, if you can, we can change the slide. So if you look at the milestones in conduction system pacing CRT, it already have started in 2000 with the paper by Deschmok as a form of treatment for conduction for heart failure. That was his bundle pacing and for narrow QRS. Then 5 years later, Morina from Spain used his bundle pacing in a patient with left bundle branch block and showed that we can use the old concept of Narula to correct left bundle and have an excellent form of resynchronization. Then a great milestone was in 2017 when Huang showed that you can do the same with left bundle branch block with left bundle branch pacing, which seems like a method dedicated to cure left bundle branch block, which in most cases is proximal. And then another milestone would be this paper that shows a very serious data, multi-center data and big group, that CRT by conduction system pacing may actually be better than by VCRT, which is already pretty good form of therapy. But the question that this paper does not answer is how to reconcile the fact that we can do the same thing with his bundle pacing and with left bundle branch pacing. So which method should be preferred or used in an individual patient? So every center has to find its own way, and I will show the algorithm or approach that we have kind of worked out in our center to deal with this. Please change the slide. So what you see is our approach. I called it APARA, as physiological as reasonably achievable, to highlight that we believe that we should start with the HIS, which is the most physiological approach and least invasive. And then if that is not possible, not feasible, or it takes too much time, then we can downgrade our physiological approach to something that is more feasible in our particular situation. So as you can see on the left arm, it's primary HIS. If HIS can be promptly obtained and you can do it well with all checklist conditions are there, because we have modified the HIS bundle implantation technique to avoid late threshold rise, then you should settle for it. If not, then you should go for left bundle branch pacing. And if that is successful, that's it. If it's not successful, then you may go to the right side of the algorithm, that is bail out his bundle pacing pathway, which means that if your his bundle attempt was not successful when you tried it for like 1 or 2 minutes, it might be successful when you spend like 10 minutes on it. So this is like a bailout his bundle pathway once the left bundle branch approach is difficult. So this is our APARA approach, and to show you how it works in real life, I decided to present briefly my last case. It just happened 4 days ago. Please change the slide. So this is not a pre-selected case. I decided just to take my last CRT case that I did. So as you see, this is a classical left bundle branch block patient recorded on November the 8th, 5 days ago. Broad QRS, 170 milliseconds, all Strauss criteria there. Heart failure, ejection fraction 23, high NT-proBNP, etc. And some problems with the septal in MRI. So I was thinking maybe left bundle branch pacing will be difficult, maybe his will be better. Please change the slide. So my first step in my stepwise approach to this APARA algorithm is to always give contrast and always use deflectable sheet. So why? Because I want to localize this tiny place but where the his is with contrast easily without blindly looking for it. And as you see, it was found with the contrast, and then we put the arrow on that place, and when you put delete on that spot, most often the his is waiting there, and that was exactly like it was in this case. I was not looking for the his was exactly there where the contrast indicated it will be. So this is my approach. Please change this slide. So once the his was, well, this is just illustrating why it is important to give contrast. You see, the his can be, sometimes it can be shifted to the right, sometimes it can be over the spine, and sometimes the shift, when there is a gigantic array, the shift can be to the left. So you don't know. Well, you can do it without the contrast if you are experienced, but I think it's much faster and much more precise when you give contrast. You are not doing it blindly. Okay, that's a little digression. Let's go back to the case. Next slide. Okay, so on this slide, you see what we have achieved when I just put pacing on that lead that was still not deployed. You see the left bundle branch block change into narrow QRS. So what we know at that moment, we know that we have a proximal left bundle branch block, not a distal one. Why? Because with the lead not deployed, just barely on the his, if you can correct the block, that means it's not on the bifurcation, it's not in the left bundle, it's in the his, because the virtual electrode cannot reach to the septum of the left bundle when the lead is not screwed in. Another insight from that moment is that we know what is the R-wave peak time of a normal QRS. It's 100 milliseconds. That will be a reference value for us later on. We'll see. Let's please change the slide. So why it will be a reference value? Because we know if you look at the density curves at the bottom, that the his bundle R-wave peak time corresponds to LVSP R-wave peak time, while the left bundle branch capture needs to have a shorter R-wave peak time, at least 10 milliseconds. So if we do left bundle branch pacing in this case, not his bundle, we would expect R-wave peak time to be at 90 or below 90 milliseconds to have a capture. Okay, please change the slide. Okay, so we deploy the lead, and I do it always with continuous taking, not only for the left bundle, but for his bundle as well. So this is what we see. You see here on the left, it starts with a broad QRS, septal QRS. Then suddenly we have a narrow QRS narrowing. This is the moment when the lead activated the his bundle, and then it changes into selective QRS of right bundle branch morphology. And this is a nice puzzle, because you see, when we stopped pacing or when we lowered the output, we have a left bundle branch conduction. I was thinking we'll have a left bundle full complete block, because now we have right bundle branch block, the patient had left bundle, we should have a systole. No, the supraventricular conduction is with left bundle, and when you pace the his, it's right bundle, but it is without any doubt an indication that we are distal to the lesion in the his bundle, because we have right bundle branch block. So we are distal to the lesion, which means the lesion is proximal. Please change the slide. And next one. Okay. The beauty of the continuous connection is not only that you can see constantly how the QRS changes during pacing, but you can even fine-tune your pressure on the his bundle during mapping. On the left, you see a figure from the paper that will be published in the Arrhythmia Electrophysiology Review, where you see how the his bundle changes into negative his bundle, how the current of injury slowly rises. This is a beautiful insight that can guide the lead deployment during pacing. But in this case, we had these tracings on the right. So we had a nice current on injury, and we had this negative his that you can see on tip filtered electrogram. So, but the threshold was 4 volts. So now we don't know what to do. We have a high threshold. Let's change the slide. We have a high threshold, and I need to go through all my checklist points to sign them off if they are fulfilled. And as you see, the threshold should be below 1.5 volt for me to accept it. And we had 4 volts, but we had current of injury. And if there is a current of injury, you need to wait. Please change the slide. So I have been waiting for 10 minutes, and it was still high. It's still over 2 volts after 10 minutes. So I decided to go for the left bundle branch pacing. And here you see the continuous deployment of the left bundle branch leads through the septum, and you see how the current of injury changed from small at the RV position and deep septum. And then we had a slight kind of injury drop, which usually coincides with capture of the left bundle. Please change the slide. And now you see what happened in the electrogram at that moment of current of injury drop. And you see two fixation peaks, which were LVSP fixation peaks. And then we had a QRS, which is pretty nice, with R wave in V1, which had the R wave peak time of 88. 88 means that the delta R wave peak time from the His bundle position was 12 milliseconds, which per the published paper means that we have a capture of the left bundle. So it looks like you will leapfrog from the deep septum immediately to the left bundle branch pacing without the LVSP phase, which is nice. So we have another nice QRS. Please change the slide. We have another nice QRS, but we don't know if this is capture of the conduction system for sure, because all these criteria, including the one where you look at the delta of the R wave peak time delta, is just statistics. The thing that really proves capture is selective QRS. And in this patient, the only way to obtain selective QRS was to do program stimulation. This is exactly what you have here. Program stimulation S2 is a selective QRS. So I know I have a capture of the conduction system. Please change this slide. And now we have two nice QRSs, His bundle and left bundle. His bundle, if you look at it, is slightly nicer, slightly narrower, less QRS area. So which one to choose? Well, in the meantime, the threshold of the His bundle dropped to 1.7 volts. So it's already slightly over my level of acceptance, but it's not that bad. Please change the slide. So which one to choose? Actually, the decision tree for me involves also the hemodynamic measurement. If you see here, His bundle pacing was definitely better than native conduction. There's a lot of variability related to breathing. Please change the slide. But if you measure precisely, there is 10 millimeter difference between the upper and lower values during the His bundle pacing and native rhythm. So I knew that the His bundle pacing is working, and the threshold was not that bad. So I actually, please change the slide, decided to keep them both. Keep them both because this was CRT box, so I could put the His in the left CS, let's say, port, and the left bundle branch pacing lead in the RV pacing port. So I could choose both of them. But the His was better hemodynamically and was better QRS-wise. I decided to pace mainly His, and then next day the threshold was 1.5. So I think this will be His bundle pacing with left bundle branch pacing backup. But looking at the APARA, what we had here, we went to the primary His bundle pathway, but then the checklist conditions were not fulfilled. So the arrow leads us to the attempt left bundle branch area pacing, and this was done and was successful. And then we reassessed the His bundle position because of the current injury, the threshold improved. So I finally kept both His and left bundle. But if I had only one of them to choose, probably I would choose His bundle in this situation. And that is the summary slide, and I would like to finish here for the sake of time. Thank you.
Thank you very much, Marek. We'll have discussion later. Now let's invite Dr. Cano to present on how do we use stylet-driven leads and also his experience in doing conduction system pacing in complex congenital heart disease.
Okay, so my first topic is going to be the use of a stylet-driven leads for left bundle branch area pacing. As we all know, the initial experience in conduction system pacing was obtained with the use of the Select Secure 3830 lumeless lead. But during the last years, stylet-driven leads from different manufacturers have been also been increasingly used for conduction system pacing. Can we move forward? Next. Okay, so next one. Next one, please. So we have to be aware that the lead design and the structure of a stylet-driven leads is going to be significantly different in comparison with the lumeless leads. So basically, most of the stylet-driven leads are going to have an extendable and retractable helix with tip electrode, which is the active electrode, ranging from 1.5 millimeters of length up to 2 millimeters. Next slide, please. Next. So these differences in the structure and lead design of stylet-driven leads are going to determine a different technique for lead deployment. So with the stylet-driven leads, the helix needs to be extended before starting lead deployment. And there is also a risk of unwanted helix retraction. So we have to be aware of this and check during the deployment process that the helix is completely extended. We know from experimental studies that with the stylet-driven leads, we have more torque transfer with the stylet-driven leads. But at the same time, we know that the stylet-driven leads are more prone to helix damage. And an interesting feature of a stylet-driven leads is that it is quite easy to use continuous pacing and impedance monitoring during lead deployment, which is also possible with the loomless leads as Dr. Jastrzębski showed us before, but you need a dedicated revolving tool for doing this with loomless leads, while it is quite easy to do with the stylet-driven leads. Next slide, please. So this is an example of continuous pacing with an stylet-driven leads while deploying the lead in the septum, so we can continuously monitoring the changes in the QRS morphology during lead deployment from deep septal pacing on the left side of the slide. Next. Next and next. Towards LV septal pacing in the middle of the panel. Can we go back? And basically, we can see the evolution of the pace QRS morphology while we are penetrating the lead inside the septum. With respect to the learning curve, for stylet-driven leads, we have very few data published so far. Next. But we know that we need around 24 to 25 cases in order to achieve the plateau for procedure and fluoroscopy times when using the stylet-driven leads. And what we also know is that we need to observe independent learning curves for both loomless leads and stylet-driven leads, even if you have a high previous CSP experience. Next slide, please. So the question is how to choose between stylet-driven leads and loomless leads. We don't have a definitive answer to this question, but we know that there are no discernible disparities in the electrical parameters between both lead types. We know that we have higher power for lead penetration with the stylet-driven leads. And we also know that the major weakness of a stylet-driven leads is observed in the helix, as we mentioned before. So the final decision should be based basically on the operator experience. With respect to the clinical success and lead performance, there is little data published so far in the literature. This table summarizes the principal series comparing stylet-driven leads with loomless leads, showing that the acute implant success rate is comparable between both lead types. Next, please. With respect to lead implant time and fluoroscopy time, these are significantly shorter with the stylet-driven leads, and there are no differences in terms of the electrical parameters, and also with respect to the incidence of septal perforation. But helix damage is being reported to be significantly higher when using stylet-driven leads, and this may be related to the implant technique employed with these leads. Next, please. With respect to the future perspectives, there are ongoing randomized studies comparing loomless leads and stylet-driven leads, such as the STYLE LVBP, which is currently ongoing in Spain. Next. There is a lack of long-term lead performance data, especially with the stylet-driven leads. And we need the development of new lead implant tools, and specifically new lead designs. For example, stylet-driven leads with a fixed helix, which will be probably helping us to avoid helix damage during lead deployment of the stylet-driven leads. Next, please. So moving now towards a completely different scenario, which is the use of conduction system pacing in children and congenital heart disease. This is actually a challenging scenario where we are going to deal with patients with a smaller body size, with surgical sequelae, with problems with long-term venous patency. The somatic growth of the patients is also an issue, as well as the long patient survival. And an important issue is that these patients are at really high risk of developing pacing-induced cardiomyopathy with conventional right ventricular pacing. So it's really interesting to have the opportunity to use a really physiologic pacing modality for these patients. Next slide, please. So specifically for congenitally complete atrioventricular block, we don't have dedicated specific implant tools, and we typically use the 315S4 and 315S5 sheaths, which are sheaths that were designed for selective site atrial pacing, but that work really good for these small patients. Next. Next, please. The implant technique is going to be similar to the technique that we employ for the adult population. Next. And it is advisable to have a peri-procedural assessment of the interventricular septum width in these patients. And typically, we don't need a backup lead for these patients with complete congenital complete atrioventricular block, because they usually have a very reliable baseline or escape rhythm. And the small series published so far in these patients have reported significant improvement in New York Heart Association functional class, and also improvement in the left ventricular ejection fraction of those patients who had previously developed pacing-induced cardiomyopathy with conventional right ventricular pacing. This is an example of a patient with congenital complete atrioventricular block, highlighting that in this patient it is very important to adjust at the end of the procedure the lead slack, because these patients are going to be continuously growing over the years. Next slide, please. Conduction system pacing has been shown to be also safe and feasible in moderate and complex congenital heart disease. But for these patients, we need specialized teams with experience in both conduction system pacing and congenital heart disease, because we are going to deal with unusual anatomical disposition of the conduction system. For example, in patients with atrioventricular septal defects, we are going to find a posteriorly displaced AV node. And in patients with a systemic right ventricle, we may find significant changes in the disposition of the conduction system. This is highlighted in the next slide, showing the disposition of the conduction system in patients with a transposition with the great arteries. So in the left, we can see an schematic representation of the conduction system in a patient with the detransposition of the great arteries after a natural switch operation. So these patients usually have a normal disposition of the conduction system, but our access to the subpulmonic left ventricle has changed, and now we have access basically to the left conduction system. On the contrary, in patients with a congenitally correct transposition of the great arteries, depicted on the right side of the slide, these patients have a complete ventricular inversion and also a complete inversion of the bundle branches. And we have access here to a subpulmonic left ventricle located in the right side of the heart of these patients. So basically, we can access to an anteriorly displaced His bundle, and also to the left bundle, which is going to be located in the right side of the septum. So very challenging anatomy in these patients. Next slide, please. So for these challenging anatomies, it is advisable to use a periprocedural evaluation with image techniques to know the real anatomy of these patients. The right side axis may be advantageous in some cases, such as patients with dextrocardia or patients with detransposition of the great arteries after the atrial switch operation. Electron anatomical mapping is also advisable for complex anatomy. And also intraprocedural image techniques such as ventriculography using contrast through the sheath may be helpful. Next slide, please. So this is an example of a patient with a congenitally correct transposition of the great arteries with dextrocardia, where we use electron anatomical mapping for depicting the anatomy of the patient and also for tagging the position of the conduction system. Next, please. So we can also use intraprocedural contrast through the sheath to delineate the anatomy of the right ventricle to select the lead insertion site in patients with an enlarged right ventricle, such as patients with a tetralogy of Fallot. Next, please. In terms of CSP outcomes in these patients with congenital heart disease, we have limited observational data, but showing that CSP is safe and feasible in these patients. Next. But with comparable electrical parameters with respect to the general population, and also showing improvement in echocardiographic and clinical parameters, and also showing that CSP is also feasible for those patients with CRT indications and congenital heart disease. Next, please. Next slide, please. And this is the largest series published so far of conduction system patients in patients with congenital heart disease, showing that in a small subgroup of patients, 25 patients with CRT indications, CSP was feasible and show a significant reduction in the left ventricular ejection fraction and also a significant reduction in the QRS duration of these patients with CRT indications. Next slide, please. So summarizing, with respect to the use of stylet-driven leads for left branchial pacing, we have to be aware that lead design and the structural characteristics differ between both lead types and may influence the implant workflow and lead performance. Direct comparisons are scarce and imbalanced because we have longer experience with lumeless leads. Next, please. We know that implant success and electrical parameters are comparable between both lead types, but we have a higher rate of lead damage with the stylet-driven leads, probably related to the implant technique. And with the current knowledge, no specific recommendation of one lead type over the other can be made, and the decision should be left to the implanter's preference and experience. With respect to the conduction system pacing in children and congenital heart disease, we've seen that CSP appears to be an ideal pacing modality for these patients that have a higher risk of developing pacing-induced cardiomyopathy with conventional myocardial pacing. CSP may be challenging in this scenario due to anatomical variations and lack of dedicated implant tools. Observational data has proved safety and feasibility of CSP in this setting for bradycardia indications, and also showing improvement in clinical and echocardiographic outcomes. And also CSP is feasible for congenital heart disease patients with CRT indications. And finally, we have to be aware that CSP in this setting should be performed by specialized and dedicated teams. So thank you very much for your attention.
Thank you, Oscar, for that wonderful presentation. In the interest of time, we can go to our discussion on follow-up and troubleshooting complications. Can we have our slides, please? Next slide. So I just wanted to put up this question on the threshold testing and nuances for follow-up. Next. Next slide, please. Can you move a little more? Keep going, keep going, keep going. One more. Okay, stop there. So when we do threshold testing with bipolar, you'll see often two transitions. You go from anodal capture to non-selective left bundle branch pacing. And in this example, you can see from non-selective to selective left bundle branch capture. Next slide, please. So often we used to treat the patients with bipolar pacing, and this we used to have because it obviates the right ventricular conduction delay due to anodal capture. But it can lead to unwanted consequences when threshold testing is performed only in bipolar configuration. Next. So apologize for the poor slide quality. This patient underwent pre-discharge threshold testing, and you can see transitions here. One transition is seen in this particular patient. There's non-selective to selective, what happened at around 2 volts. And next slide, please. Next slide. And so, and the loss of capture was at 1.25 volts, and this patient was ready to be discharged. And I was a little concerned that the threshold for selective capture was at 1.25 volts, while it was much lower at implant. And so when we did unipolar threshold testing, there was no capture. Next slide, please. So this is the question for the panel. And what is the routine in your center? Do you do unipolar and bipolar, which was our standard? And occasionally some physicians or technicians, when they do the testing, they forget to do unipolar. And so how do you practice? Is it always both uni and bipolar, or you program unipolar? And Marek, what is your practice in your center? And Oscar, you can answer after that.
At the end of procedure, all patients are programmed to unipolar pacing just to avoid this masking of loss of capture from the tip on the next day. And all patients have a threshold test on the next day obligatory apart from chest x-ray. So this is how we have found 2 late perforations in our cohort of 2,000 patients. So far this works well for us. No really late perforations were observed apart from these 2 next day cases.
Yes, the same for us. We always program unipolar, but we perform the bipolar pacing threshold also during follow-up, just to be aware about concerns of perforation. So this is really important to remark. Yeah.
Thank you. So we also had 2 perforation within 24 hours, and all detected because our routine testing both uni and bipolar. But I was concerned that many programmed to bipolar pacing. So our institution, as a policy, we've changed everything to program to unipolar pacing more. And we've also learned that anodal capture does not add significant value in terms of improving hemodynamics, at least in the cardiomyopathy patients. So we don't lose much by having a little bit of right ventricular conduction delay. Thank you for that input. And I think it's important that unipolar testing is important, and probably programming unipolar is probably the best way to avoid any trouble or to miss any late perforations in this patient. Next slide, please. So this is the echocardiogram, and this is a potential for embolic complications, and we want to avoid this by taking this particular issue quite seriously. Thankfully, this issue is very uncommon, but it's a serious one. Next slide, please. And then histonal pacing is the least invasive This was a patient 1 day post left bundle branch pacing lead implantation with a very large hematoma. I just want to ask the panel, have you encountered this? How often? And if so, what do you do to manage these patients? In the literature, there are a few cases reported. Oscar?
Well, if I
Yeah, go ahead, Mark.
Yeah,
May start.
septal hematoma, in my experience, it's a really rare complication. I always check my patients with a transthoracic echocardiography before and after the procedure, immediately after the procedure. And septal hematoma has occurred just in 3 patients in my experience, with more than 1,000 patients included. But obviously there are reports in the literature of this rare complication. In my own experience, the cases that I have had have spontaneously resolved, and no one has been as dramatic, and this one shown by you, Pugel. But yes, it's a concern that we had to observe, especially when we are doing multiple attempts for lead deployment in the septum. So we have to check that everything is okay with the septum after the procedure.
Mark, what would you do
so
to avoid
we have not seen cases like that in our experience, but I've heard about 2 cases from other Polish labs. So it's out there, but it seems, and I don't know why we have not seen a case like that, although we do perform echo in our patients.
So I think one of the reasons this particular patient was on triple therapy, so that may be an added issue. But deploying it too anteriorly or too posteriorly, where the larger perforators are there, especially in the proximal interventricular septum. So that's something to be avoided. But I've seen this published cases even with the lead placed somewhat more distal towards the apical. And just the unfortunate occurrence of arterial perforators and our lead meeting that perforator and causing the bleeding. In this particular patient, we were able to, next slide please, we were able to manage conservatively. Next slide. And over a period of 6 weeks, it completely resolved. And the interesting aspect of this was that the lead threshold didn't change at all. We still had good non-selective to selective capture, even at the end of the 6-week follow-up. Next slide, please. Next slide. So one of the few other points for discussion is that commonly asked is how often lead extraction and what is the risk of lead extraction, both for his bundle pacing and left bundle branch area pacing. Oscar or Marek, you can talk about your experience. You are a part of the consortium group that published this TechSpam study where we presented ease of extraction of these leads. Can you keep moving the slides, please? Well, Oscar, you can comment on.
Yeah, so fortunately, the need for lead extraction with left bundle branch area pacing is really low in my experience. So the number of cases is low, and the lead wheel time is being small so far. So the older leads that we have extracted from the left bundle branch area has been 2 or 3 years, up to 3 years. And in our experience, we haven't had the need to use additional tools for lead extraction, just the extraction without any additional tools has been enough for all of our patients. So really good experience. There are usually no need for additional tools in our experience so far.
Yeah, so this was a multi-center experience, and we were able to show that the complete lead extraction success was about 99%, and clinical success in extracting all of the leads except for the distal tip was 100%. So as you can see, the manual traction was adequate in the 90% of patients. Sometimes even in 10-year-old his funnel pacing lead, the longest left funnel branch area pacing lead extraction in our center is about six years, and the lead came without any need for extraction too. So while acute observations are good, we still need to diligently follow, do we have any potential issues? There are cases of distal tip being embedded in the myocardium and not being able to extract, which may not be a major disadvantage, but it's something to be concerned about for the future. Next slide, please. So one other thing that came up is what is the risk of lead failure? This again, Jan Dipuda and Haran Buri put together this large series of about 8,000 patients. And Marek and Oscar, do you have any concerns for incidence of lead fracture, and how do you avoid it, or which leads, and do we worry about this for the future, and do we need more studies to understand this phenomenon?
It seems that the angle, creating of this angle is very important to have some kind of prevention of lead damage. So sometimes when you implant and you have a very strange angle, I would remove the lead and implant it again to have a more smooth transition from the cavity to the septum. That means that the lead should actually not be that perpendicular as you would like it to be, because the more perpendicular you are, the greater the angle you create and put the lead at risk. So maybe we should start lower or start more basal and be more oblique in the septum to have more delicate passage of the lead and avoid this. That's my thought. That's the only prevention that I use.
Yes, I agree with Marek. I think we should pay attention to the angle between the lead and the septum, because sometimes we can identify some strange angles between the lead and the septum, and the lead appearance inside this, the lead tip appearance inside the septum is strange sometimes. And I agree that when I see this in the fluoro, I change the lead position, because I have concerns about what may happen with that lead in the future and the risk of fracture.
Yeah, so you're correct in that observations. In this particular study, the incidence of lead fracture was slightly higher in the stylet-driven leads. One factor that was noticed was, especially with the stylet-driven leads, there is a flex point between the tip and the ring. And when you advance the lead without the stylet being all the way to the tip of the lead, you can create these funny angles between tip and the ring. So in addition to the angle between the septum and the lead, this angle between the tip and the ring electrode is probably critical. That may cause more stress for the stylet-driven leads. All right, so any other questions you have within the panel?
The thing that comes to my mind with prevention of damage to the lead is maybe we should have a cutoff for how many attempts you can do with one lead before changing it to another lead, because if you have a difficult procedure, you are more likely to do some funny movements and produce actually a damage in the lead before deployment, maybe.
Yeah, and I think it is also important to monitor the lead behavior during lead deployment. So if you identify entanglement, you have to stop immediately, keep trying to deploy that lead in the same position. So I think that's really important to observe the behavior of the lead in the septum when you're starting lead deployment. If you identify lead entanglement, just stop there and remove the lead from that position and try a different position, because otherwise you are going to get into trouble probably with that lead.
Absolutely.
Yeah, over-torquing the lead is probably causing damage not only in the inner conductor but also the insulation at the entanglement site. Even when the lead is halfway in and you're not able to advance further because of fibrosis, scar. So I have a policy in our lab After about 20 minutes of use of any lead, I would change the lead because you probably created enough stress for that lead.
Good policy.
Do we have any questions from the audience? So one other question that I see is that, are there any differences between stylet-driven leads? We have almost all of the manufacturers have the leads now indicated for left bundle branch area pacing. And do you have a preference? And if so, any particular reason why you would use one lead over the other? Oscar, you want to?
Yes, well, I don't really have actually a real preference between the stylet-driven leads. I have much more experience with the leadless leads, but I have employed all of the currently available stylet-driven leads. Lead behavior may be slightly different between some of them. For example, if you use the UltiPace lead from Abbott, has a really good torque transfer because it has a special design in the proximal part of the lead that gives you a good torque, an excellent torque transfer. So that's a really nice feature of this particular lead. But also leads from Biotronic or from Boston Scientific have a good behavior during lead penetration. The main advantage of stylet-driven leads is that you have more power for penetrating the septum, but you also have to be aware that you have to be cautious about that power, and you have to manage that power in the correct way in order to be successful during these procedures when using the stylet-driven leads.
Yeah, so there was a recent randomized study comparing stylet-driven leads versus lumenless leads, primarily with the tender leads as well as with the Medtronic 3830 lead that was presented at the APHRS by Professor Rajiv Pathak. And your point is well taken. There was no significant difference in terms of success or pacing outcomes, but there was a significant incidence of acute perforations. Not clinically relevant, but acute perforations are more common, the stylet-driven lead. It's the power of torque transfer, because those of us who are used to 3830 would like to do rapid rotations, and so that we can move fast in one attempt to get through the. With the stylet-driven leads, you need to slow down a little bit, not be as rapid as we used to do with the 3830 leads. Marek, what is your preference in terms of leads? Is there a choice between in patients with cardiomyopathy or enlarged atrium? Do you find luminous leads to be better or easier for you, or is there no difference and you can make it work in any situation?
Well, I have only experience with 3830 and Solia, so I can't compare other stylet-driven leads. I mainly work with 3830 because I believe that the experience is more important than the tool that you use. So I tend to stick to 3830. And my experience with Solia is that yes, it seems that you have more power, but at the same time, the footprint is bigger. So it's somehow balanced, and I don't somehow see greater ability to pass through the fibrous septum than with 3830. Actually, I sometimes think that the thinner lead is better to pass through the fibrous septum than more stiff, aggressive lead, which will have a bigger footprint. But this is just personal observation, so I don't know if this is really true.
I think we have to learn through our experience. Okay, now I can see. Okay. So one of the questions is that what is your protocol for determining if a patient with heart failure and left bundle branch block should receive CRT versus conduction system pacing? Marek, you want to take this?
Well, yes. Our approach is to start with conduction system pacing, and by if you look at the APARA protocol, is still there, but at the very, very end, when the left bundle branch fails, when his bundle fails, then we have lot CRT, hot CRT option, and if that fails as well, then the conventional by V is still there, but slightly at a slightly lower level of the ladder, the physiological ladder of the APARA approach. It's still there, but not as a first choice approach. We tend to differ from what is recommended by the guidelines.
Oscar, what is your approach?
In our center, we still our first approach is still conventional biventricular CRT for conventional CRT indications, and only for specific patients, for example, patients with patient-induced cardiomyopathy undergoing CRT, those patients we use systematically conduction system pacing from the beginning. But for the rest, and waiting for the results of randomized trials, we still go first with conventional biventricular CRT. And just in case that we are not able to implant a CS lead, then we use conduction system pacing as a bailout procedure.
Yeah, our center we still used almost similar to the power technique, because his bundle pacing gives us an answer of what type of conduction disease you have, and if it's pure left bundle branch block, and I think conduction system pacing is superior, although we only shown in small randomized trials in large observational studies. For everyone to follow that, we need to wait for guideline change as well as large randomized trials as those you're part of, and Marek and I are part of some of the other randomized trials. So I have a few other questions. One of them is, what do you both expect from your physiologist during implant? Do you have a physiologist? I mean, I know physiologist is our integral part of the team in UK. I don't know, well, I don't have a physiologist in our lab, but Marek or Oscar, do you have any of them in your lab?
We do have physiologists, and you need to train them to be something more than they used to be. It's not just threshold test anymore. They do program stimulation routinely. They look at transitions. We have multiple leads connected to the EP system. Now implantation is a kind of small EP procedure for us. And because they are pretty good with the 3D systems, it was not that difficult for them to really adapt to the new situation. And we have workshops, and also the physiologists from other hospitals come to us, and they learn how my team works. And I think that's the way of the future, to have a physiologist who knows what conduction system pacing is and support you during the procedure.
We don't have that figure in Spain, the physiologist, and we rely on our nurse team, which is fully aware of the technique and really help us a lot during the whole procedure, not only with the thresholds, but also perform all the measurements in the EP recording system. And I think that's essential, that you have a whole team involved in this technique.
You're right. You need to have as many set of eyes and hands you can get during this procedure. It's quite helpful. I have a few more questions. What is the strategy would you implement in heart failure with reduced ejection fraction, right bundle branch block, and wide QRS? Conduction system pacing first, or LV CS lead placement?
For right bundle branch block patients, yes. So that's a subset of patients with wide QRS, where we really try first with conduction system pacing. And well, we before the procedure, we use some techniques for determining the nature of the desynchrony of these patients. So we use ultra high frequency EKG to figure out which is the real conduction disease of the patient. So if we see any delay in the left ventricle activation in those patients, we are going to try first with conduction system pacing.
The critical thing is masquerading or not left bundle branch problem, because if this is pure right bundle branch block, then we just implant regular pacemaker, regular ICD with conduction system lead that corrects that, but not for especially as a resynchronization, but just to maintain the rhythm. But if there is a masquerading right bundle branch block, then we follow the same path as for regular CRT, which means CSPA as well.
Yeah, hopefully there is a randomized trial, his CRT, it's an NIH-sponsored trial, about 120 patients, run by Valentina Kutifo and Roderick Tung. And the results, we have enrolled about 102 patients as of this week. and hopefully we'll be completing enrollment within the next 2 months and 6 more months of follow-up. Hopefully by next year, this time, we'll have the results of that study. Hopefully it'll guide us what would be the best answer in that particular type of patients. There's one of the questions on, can you elaborate on the long-term outcome data comparing his bundle pacing versus left bundle branch area pacing for CRT? Yeah, I think we have limited data. We've looked at this as part of our I-class group, which all 3 of us are. In the mildly reduced LV ejection fraction group, 35 to 50%, we had enough patients in both groups to compare clinical outcomes. And there was no difference in terms of death or heart failure hospitalization or even EF change. They were all similar. This was about 175 patients with spinal pacing and about 600 plus patients with left bundle branch area pacing. Unpublished data on the I-class study for BIV versus left bundle branch pacing, we had about 170 patients with his bundle pacing, and we didn't see much difference. But groups are somewhat different, slightly baseline characters. That's why we didn't include them. I anticipate, as Marek pointed out, we prefer his bundle pacing. There would be a difference, but that difference may be minimal at this point. We need a large number of patients to show the difference. All right, that brings us to the end of the session, and I want to take this opportunity to thank my panelists, Professor Jastrzębski and Professor Cano, for joining us, and also the Arrhythmia and Electrophysiology Review Journal and the team, and also the Radcliffe Cardiology for organizing this webinar. I hope you get to read all of the multiple articles that has been put together for this particular edition of conduction system pacing in the Arrhythmia Electrophysiology Review. Thank you very much for joining us, and hope to see you next time soon.
Thank you, Pugal.
Thank you.
Thank you.